Hello everyone. Now I'll discuss question of psychiatry. Well, we are getting a 67-year-old man who come to you with his wife due to increasingly difficult performing his job over the past year. He has become more irritable at work, acted inappropriate many times, has got into argument with his boss also for the first time in last 20 years. Now, patient is now described as distant by his co-workers who previously thought him as a very friendly, but now he's maintaining distance. His office has become increasingly cluttered. He refuses to throw away things which are waste, and he has forgotten to submit numerous assignments. His wife echoes similar concern in the home also. Describe him as a withdrawn person, emotionally detached, not the man I married. In addition, patient eats only certain foods and less interested in this appearance. He lost interest in golf also, one of his favorite sports. Patient has a history of well-controlled hypertension and hyperlipidemia, but no history of psychiatric disease. He has 30-pack year of smoking. Which of the following is the most likely diagnosis of this patient? Well, answer is frontotemporal dementia, that is option B. Why this? Why not others? If you look into patient symptom and course of illness, they are most consistent with behavior variant of frontotemporal dementia. What do we write as FTD? It's also known as Pick's disease. It is characterized by focal degeneration of frontal and or temporal lobe. Mainly frontal is involved, temporal may or may not be involved. Family history may be positive in such cases. Now, what are the clinical features of this condition? Personality and behavior changes, disinhibition or apathy. Well, what's the reason behind this? For that, you got to know basic concept of neuroanatomy. Well, we say this is central sulcus, this the motor cortex, and this is frontal lobe. Here is the prefrontal cortex. It is this area which is concerned with social behavior and personality. When in FTD, this part is involved. And that's why he has loss of social inhibition. Classic example of loss of social inhibition is if you find an adult man passing urine in public, in the road, openly in a classroom or in a conference, no inhibition. That is the one example of disinhibition. So, and this happened, as I told you, the primarily frontal cortex is involved, especially the prefrontal cortex is involved. Other thing is compulsive behavior, hoarding, hyperoral. Hoarding means he will tend to retain all waste. Like in this case also, his office is cluttered. He tend to retain all waste paper, towel papers, waste papers, etc. Used tissue paper he tend to retain. He will not like to throw away. This is called hoarding is there. Okay. Executive dysfunction, look, he's not having proper behavior. He's arguing with the boss and he's keeping distant from all the co-workers. Memory deficit tend to appear later in the disease course. Can you give the reasons? Stop the video, write down the answer. Why memory deficit tend to be late? Write down the answer in your copy, stop the video. Well, the answer is, as I told you, in this case, the patient, usually frontal lobe is involved. Temporal lobe may be involved. Memory is a function of temporal lobe. So that's why the patient problem start with the frontal lobe, later on temporal lobe, and when temporal lobe involved, then come the memory deficit may be there. Well, one more thing, FTD involve earlier onset as compared to other dementias like Alzheimer's disease. Little early maybe, and maybe in the 50s, 60s, in contrast to Alzheimer's where it is 60 to 70 years, little older. Well, and 25% have a strong family history. Fairly good percentage, 25%. Well, so early symptom are apathy, personality changes, which I mentioned in the previous slide because of involvement of prefrontal cortex. And this may be sometime patient, initially we think patient is depressed or maybe some other psychiatric problem is there. Well, we have to differentiate from Alzheimer's disease, dementia with Lewy body and vascular dementia. They are important conditions which are the important DD of any case of dementia. Well, let's talk about dementia with Lewy body. This present with visual hallucination, classical question, cannot afford to forget this line. Patient has associated Parkinson. Rather, Parkinson patient having visual hallucination, then we have to keep the possibility of Lewy body. REM, sleep behavior disorder, occurs in this. Well, fluctuating cognition and variation in attention and alertness may be misdiagnosed as delirium. Because in these patients, in Lewy body dementia, these are features which definitely may confuse with delirium, which is usually due to some acute problem. Hoarding disorder, which I mentioned, typically seen in young age, teenager years. As I told you in the previous slide, they are unable to dispose of items that may be of no actual worth, magazine, paper towel, etc., old newspaper, etc., which we tend to throw away. He will not throw away. This is a hoarding disorder, more in young people. And it tend to, and resulting in significant and often dangerous physical clutter in the home environment. Definitely, if these waste are not thrown out, they are definitely going to create the environment to be, clutter will be there in the home or office like in this patient. But thing is, this disorder occurs in teenager and our patient is above 60 years. Okay, so this is not a hoarding disorder as per se. And it worsens with age, definitely, but that will young age start, long history will be there. But in our patient, it's the recent onset hoarding behavior, not in the past, so this is ruled out. Moreover, there is marked personality changes there, his bad behavior, arguing with the boss, no interest in golf. So they make the diagnosis of total pure hoarding disorder is very, very unlikely. Major depressive order. These patients, they show withdrawn, apathic behavior and reversible cognitive impairment. It is reversible. If you treat the patient properly, they are reversible. Okay. But our patient lacks other feature or patient like sadness, feeling of worthlessness. These are the classical things that we see in any patient of depression. Okay. So his symptoms are change in personality. They better fit into FTD rather than into major depression. Obsessive compulsive disorder, OCD. In this again, they have a hoarding behavior, but they are most often associated with specific obsession are distressing to the individual. Like patient has to wash hand, he'll keep on washing hand again and again, and patient is aware, and it is distressing to him also. Okay, and present around 20 years, not at the age of above 60 years like our patient is an elderly person. And moreover, our patient has no pre-morbid psychiatric diagnosis, making OCD unlikely in the current situation. Previously, there was no psychiatric illness. He was perfectly all right. The problem started only 1 year in our patient, 1 year back. Golden line to remember, behavior variant of frontotemporal dementia FTD is characterized by early personality changes, compulsive behavior, executive dysfunction, memory difficulty tend to develop later in the course of disease. Early onset and strong heredity component is there in this. Thank you very much.